Good evening, all, for this ISCCM Journal Club for the new session. So, I, along with my co host, Dr. Satya, welcome you all for this inaugural Journal Club with ARISS trial, which is albumin replacement in septic shock. So, without wasting much time, I'll introduce our chairperson, Dr. Ranvinder Kaur ma'am, who is Director, Professor, and Head of Critical Care Medicine at RML Hospital, Delhi, and our moderator, Dr. Anirban Home Chaudhary, Director, Professor, Head of Safdarjung Hospital. So, I hand over my stage to Dr. Ranvinder Kaur for the proceedings. Thank you.
Thank you, Dr. Santosh, for a very kind introduction. Good evening to all. Today, we have a very interesting topic for the Journal Club, that is the albumin replacement therapy in septic shock, which is named as the ARISS trial. Now, this clinical trial was published in JAMA in February 2026. As we all know that for decades, human albumin has been administered to patients, and there's a convincing rationale for the potential advantages of albumin in severe sepsis and septic shock. But the efficacy of albumin is not well established, and the literature is contradictory. So there have been two landmark trials in the past to impress the mortality benefit of albumin in critically ill patients. So one is a SAFE trial of 2004, which compared 4% albumin with 0.9% saline as a volume replacement. And second we have is the LBO study of 2014, in which 20% albumin was compared with crystalloids. Now, I will not go deeper into these trials, but these clinical trials showed no difference in mortality between the two groups, though the LBO study did show improvement in hemodynamic indices in patients who received albumin. So, based on this background, the ARISS trial was planned with the perspective that the results of the trial may influence the treatment of patients with septic shock. If the established hypothesis can be confirmed, then 20% albumin use is justified in septic shock. And if the hypothesis cannot be confirmed, then restrictive use of albumin is justified. So, in both the scenarios, the results of the ARISS trial will reduce the socioeconomic burden of the disease and will also have a very high clinical relevance. So, now this is a very brief overview. Now, I would like to introduce the eminent panelists for today. So first we have is Dr. Mridul Kumar Daga, who is a professor of internal medicine and infectious diseases at ILBS. He is formerly the head and director professor of medicine and in charge medical ICU at Maulana Azad Medical College, New Delhi. His achievements are numerous. He was awarded the WHO Fellowship in Critical Care and Pulmonary Medicine. He is also a part of the International Advisory Board of Davidson's Textbook of Medicine. He has received a state award for the best doctor by the GNCT, New Delhi. He has a number of publications, close to 250 publications in all national, international journals, as well as he has written many book chapters. And Sir has got more than 400 presentations at various conferences. Welcome, Dr. Mridul, sir.
Thank you for your kind words.
Yeah. Okay. Thank you, sir, for coming, for joining, sir. Then we have Dr. Pramod Guru. He is working as Associate Professor of Medicine at Mayo Clinic, College of Medicine and Science at Florida, USA. Again, he has a number of achievements. He is the director of the Adult ECMO program. Also, he is the program director of Critical Care Medicine Fellowship at his hospital. He has a number of areas of interest. Most pertinent is ECMO, AKI, and transplant. Welcome, Dr. Pramod Guru. And then finally we have Dr. Amit Kansal. He's working as a senior consultant in intensive care medicine at a Teng Phong General Hospital, Singapore. He's a keen educator and instructor of many internationally recognized courses like ATLS, ACLS, and is involved in a number of simulation-based teaching. Again, his areas of interest are varied from medical informatics to cost effectiveness in critical care. And again, he has a very keen interest of a role of HFNC in respiratory failure. Welcome, Dr. Kansal. Now I hand over to Dr. Santosh for further.
Okay. Now I'll request Dr. Anirban Chaudhary sir to introduce the speaker and proceed.
Yes, today's presenter is Dr. Mayank Rajpal, who is the DM resident of critical care medicine at Safdarjung Hospital. I request Mayank to start his presentation. And Mayank,
good evening.
take the time. Yeah.
Good evening, sir. Sir, is my slide visible and am I audible?
Yes. Please.
Yeah,
Good evening, respected faculties. I am Dr. Mayank Rajpal, DM resident at Department of Critical Care Medicine in Vardhaman Mahavir Medical College and Safdarjung Hospital. I would like to thank Indian Society of Critical Care Medicine and Dr. Anirban sir for giving me this opportunity to present this the ARISS trial in today's journal club. So starting with the trial, the ARISS trial, that is as discussed before, albumin replacement therapy in septic shock, was published in JAMA Open Network in February 2026. A little bit of background. Albumin has always been a point of debate in critical care because it has demonstrated very physiological benefits. But on the other hand, the efficacy has not been proven in any of the trial till now. Albumin is a natural colloid and it has multiple properties. It maintains the plasma oncotic pressure. It maintains 70 to 80% of the plasma oncotic pressure, binds and transport of the endogenous molecules and the medications. It has an anti-inflammatory and antioxidant effects, and it also helps in modulation of the nitric oxide metabolism that we know is a key factor for the refractory vasopressia and septic shock. So before coming to ARISS trial, a little bit of background. Initially, in the Cochrane meta-analysis in 1998, it was demonstrated that albumin is not safe to be given in critically ill patients. It was contradicted by the SAFE trial that ma'am just discussed, that is the saline versus albumin fluid evaluation study published in NEJM in 2004, where they mentioned that albumin was safe, but the mortality was similar in critically ill patient who received either 4% albumin or 0.9% saline. However, this trial demonstrated a trend towards lower mortality in those receiving albumin in the predefined subgroup of sepsis. This prompted the ALBIOS trial, that is Albumin Italian Outcome Sepsis Study, which was conducted in 1,818 patients with sepsis or septic shock and who were randomized to receive either 20% human albumin or to maintain a serum albumin concentration of 3 gram per deciliter or more or versus crystallized solution. Although no difference in 28 or 90-day all-cause mortality was seen, a potential survival benefit was reported in patients who received albumin therapy 6 to 24 hours after the diagnosis of sepsis was made compared to those who received it earlier. And the relative risk of 90-day mortality was reduced in a subset of albumin-treated patients with septic shock at the time of enrollment. Based on this specific post-hoc analysis of the ALBIOS trial, this ARISS trial was formulated. The ARISS trial, that is albumin replacement therapy in septic shock, was designed to investigate the effect of albumin replacement on mortality in patients with sepsis and patients with septic shock. A little bit, where do we stand with the guidelines right now? The recently published Surviving Sepsis Guidelines of 2026 suggest that for adult patients with sepsis or septic shock, they suggest using crystalloids alone over crystalloids with supplemental albumin for fluid resuscitation. Although in the remarks portion, they say that use of supplemental albumin may be appropriate for patients who have already received a large volume of crystalloids. This is similar to the previous 2021 Surviving Sepsis Guidelines. The rationale for the same is that the lack of proven benefit and higher cost of albumin compared to crystalloid contribute to their recommendation for the use of crystalloid as a first-line fluid for resuscitation in patients with sepsis and septic shock. Although the evidence from previous SAFE and ALBIOS trial, that is the use of albumin provides better higher blood pressure, higher static filling pressure, and a lower net fluid balance with albumin, led the panel to propose albumin for patients who have already received large volume of crystalloids. With this background, we'll come to the hypothesis of our trial, that is ARISS trial. Albumin administration started within 6 to 24 hours after the onset of septic shock, titrated to maintain a serum albumin concentration of 3 gram per deciliter or more for up to 28 days during an intensive care unit stay would reduce the 90-day all-cause mortality. It was a prospective, multi-center, parallel group controlled, open-label, interventional randomized controlled trial. It was conducted in the 23 centers in Germany, and the patients were enrolled between October 2019 and May 2022. The follow-up was completed in July 2022. This was the main caveat of the study. It was stopped prematurely because of low enrollment rates during the COVID-19 pandemic. Patients were randomized to the treatment or the control group in a 1:1 ratio. Randomization was performed by an automated internet-based service, and they were stratified according to the serum lactate levels within 24 hours and by the trial centers. Now, coming to the inclusion criteria, they included all adult patients, that is, patients 18 years or older, and if they met all of the following criteria, that is, either the presence of a clinically possible, probable, or microbiologically confirmed infection, need for vasopressure to maintain a mean arterial pressure of more than or equal to 65 millimeters of mercury for at least 1 hour despite adequate volume therapy, serum lactate concentration of more than 2 millimole per liter despite adequate volume therapy, and diagnosis of septic shock less than 24 hours before the study inclusion, enabling administration of the first dose of albumin within 6 to 24 hours after the onset of septic shock, as was suggested by the post-hoc analysis of Albios trial. They excluded moribund patients with a life expectancy of less than 28 days, or patients having palliative care with a life expectancy of less than 6 months, or patient having any end-of-life care decisions. Or they also excluded patients with previous participation in the study or participation in any other intervention clinical trial in the previous 3 months. Any history of hypersensitivity to albumin or any other component of the trial product was also an exclusion criteria. And they also excluded diseases, patient with diseases in which use of albumin may be deleterious, like in traumatic brain injury or decompensated heart failure. They also excluded patients in which albumin administration was advantageous, like hepatorenal syndrome, and they excluded pregnant and lactating women. Now, coming to the intervention. In the treatment group, patient received a 60-gram loading dose of 20% human albumin during 2 to 3 hours within 6 to 24 hours after diagnosis of septic shock and within 2 hours of randomization. That is, once the patient was randomized, and if he lands between a time period of 6 to 24 hours after the diagnosis of septic shock, they had to give 60 gram of 20% human albumin over 2 to 3 hours within 2 hours of randomization. And serum albumin concentration were maintained at a level of 3 gram per deciliter or more for a maximum of 28 days while in the ICU stay. Now, for this, they measured serum albumin daily and used this protocol to maintain the serum albumin level of more than 3 gram per deciliter. So if the albumin level was already more or equal to or more than 3 gram per deciliter, no albumin was administered. If it was between 2.5 to 3 gram per deciliter, 40 gram of serum human albumin was administered over 1 to 2 hours. If it was between 2 to 2.5 gram per deciliter, 60 gram of human albumin was administered over 2 to 3 hours. And if it was less than or equal to 2 gram per deciliter, 80 gram of human albumin was administered over 3 to 4 hours, and serum albumin concentration were checked every morning. Now, coming to the control group. The control group was treated according to the standard of care. Albumin was administered in agreement with the current guidelines for resuscitation from septic shock if deemed necessary by the treating physician. All patients received fluid resuscitation with crystalloid. There was no restriction to the concomitant medication or therapies during the trial. The outcome, the primary endpoint for the study was 90-day all-cause mortality, and the secondary endpoint were 28 and 60-day mortality, ICU and hospital mortality, organ dysfunction or failure as assessed by the SOFA score, ICU and hospital length of stay, ventilator-free days and vasopressor-free days, total fluid administered and total fluid balance in the ICU, and safety-related parameters, that is the adverse events. Now, coming to statistical analysis, sample size estimation was performed using the SAS software version 9.4. 90-day mortality in the control arm was estimated at 50%. A 15% reduction in 90-day mortality in treatment group was assumed. A 15% reduction from 50%, that is an absolute reduction of 7.5%, letting the mortality come down to 42.5%. A Mantel-Haenszel test was with a two-tailed significance level of p-value less than 0.05 and a power of 80% required 1,412 patients to be analyzed. And assuming a dropout rate of 15%, total 1,662 patients were needed to be randomized. The primary efficacy and the safety analysis were performed in the intention to treat population and in per protocol population. Primary endpoint and selected secondary endpoints were described in 4 subgroups, that is the baseline lactate level, SOFA scores, SAPS-2 score, and Apache 2 score. No interim analysis was planned and no imputation of missing data was performed. Now coming to the actual flowchart of the trial. So initially, almost 1,600 patients were assessed for eligibility, out of which 1,158 were excluded, and 440 were randomized, 222 to the albumin group and 218 to the control group. This is much lesser than the proposed proposed sample size of 1,600 patients because of the COVID. Out of 222 patients, 77 were excluded for the 28-day follow-up. That is, 147 patients were included for the 28-day follow-up, out of which further 18 were excluded for the 60-day follow-up, and 10 were further excluded for the 90-day follow-up. That is the primary endpoint. So in the end, 210 patients, 119 patients were followed for 90-day follow-up in the albumin group and 113 in the control group. And in the modified per protocol analysis, 210 were analyzed in the albumin group and 209 were analyzed in the control group. Coming to the baseline characteristics of the intervention and the control group, the median age was 70 in the albumin group and 69 in the control group. 64% were male in the albumin group and 67.9% were in the control group. Other than that, the reason for admission was majorly post-emergency surgery. That is, almost 50% of the patients were admitted after emergency surgery in the albumin group, and 46.3% were admitted after emergency surgery in the control group. The pre-existing conditions were more or less similar in both the groups. The baseline SOFA score, SAPS-2 score, and Apache score was also similar in both the groups. The baseline physiological parameters were also similar. That is, the heart rate, mean arterial pressure, central venous pressure, lactate, serum albumin levels, and hemoglobin levels were similar in both the groups. The one difference that I could find was the need for extracorporeal therapy, that is renal replacement therapy or extracorporeal membrane oxygenation, was more in the albumin group at the baseline compared to the control group. And the fluid administration and fluid balance was also similar in both the groups at the start of the study. Now coming to the study intervention that was actually performed, the median duration of albumin administration was 5 days, with 15 patients treated for the maximum of 28 days. The mean amount of albumin administered was 229 ml per day. That is almost 45 gram of albumin. Albumin was given to 106 patients in the control group as deemed necessary by the attending physician. Given this high number of patients receiving albumin in the control group, a per protocol analysis and a modified per protocol analysis was performed. The physiological and the oxygenation parameters, fluid administration volumes, vasopressor therapy, and the procedures were similar between the two groups at 6 hours after randomization. Now, in this graph, as we can see, this graph depicts the serum albumin level in the intervention and the control group during the ICU stay. As we can see, the intervention group, the albumin level was significantly higher than the control group, but almost 50% of the patients did not reach the threshold value of 3 gram per deciliter despite giving adequate albumin. Now coming to the results of the trial, the primary endpoint, that is a 90-day mortality, was similar between the treatment and the control group, that it was 43.3% in the albumin group and 45.9% in the control group, with a relative risk of 0.94 and 95% confidence interval between 0.76 to 1.17 at a p-value of 0.71. This Kaplan-Meier curve depicts the same. Although the albumin group shows better survival, but it was not statistically significant. And the result of per protocol analysis were in agreement with the main intention to treat analysis. Now coming to secondary outcomes. Although numerically, if we see, in the albumin group, the 28-day mortality was 31%, while in the control group, the 28-day mortality was 38%. Similarly, the 60-day mortality was 38.9% in albumin group and 45.2% in the control group. Numerically, it is less, but the authors have mentioned that it did not reach a statistical significance. And other than that, the ICU mortality, in-hospital mortality, length of ICU stay and in-hospital stay, ventilator-free days, vasopressor-free days, and the fluid administered was similar in albumin group as well as the control group. Coming to cumulative fluid balance, the cumulative fluid balance at 96 hours after randomization and 7 day after randomization was significantly different in the albumin group and the control group, but the authors have mentioned that there was no statistically significant difference. And the SOFA scores in the ICU was also similar, and new organ failure in the ICU was also similar in the albumin group and the control group. In subgroup analysis, no significant difference in 90-day mortality was seen between treatment groups according to the baseline values of lactate, SOFA score, Apache 2 score, or the SAPS 2 score. And the frequency of adverse events, whether sepsis related or drug related, were similar between the albumin and the control groups, although it was numerically slightly higher in the albumin group, but it was statistically not significant. Now, coming to the discussion. Administration of albumin, aiming to maintain a serum albumin concentration of 3 gram per deciliter or higher, did not improve 90-day survival in patients with septic shock compared with treatment without albumin. The frequency of adverse events were similar between the groups, confirming the absence of any potential harm of the albumin therapy. Although previous post-hoc and subgroup analysis from the SAFE and the ALBIOS trial suggest a possible benefit of albumin in patients with sepsis, this study did not replicate the finding in a septic shock population. The routine use of albumin in patients with septic shock may thus not be justified, especially in the view of relatively high cost of this therapy. The lack of positive effect of albumin therapy on the primary endpoint may be attributed to several factors. The first being the premature termination, which made the study underpowered, which is one of the very significant points which we have to consider. And other than that, the most of the patients included in the study were post-operative. The 50% were emergency post-operative and 30% were elective post-operative. So roughly 80% were post-operative patients in whom the outcome may be significantly influenced by the surgical factors beyond sepsis management. More than half the patient did not reach the albumin target of 3 gram per deciliter during their ICU stay. Although similar was the result in the ALBIOS trial, where in their intervention group as well, they did not reach the target level of 3 gram per deciliter. Still, that ALBIOS trial in a post-hoc analysis demonstrated an outcome benefit in a cohort of septic shock patient, which was not demonstrated in the ARISS trial. The antioxidant capacity of the albumin may vary by the type of commercial albumin preparation and by the duration of exposure to the oxidative stress. As demonstrated in unpublished data, almost 30% of the antioxidant property of albumin get lost with the severity of sepsis. So in this study, they have used two different kind of human albumin, two different preparation of human albumin from different companies. So the antioxidant property of the albumin may vary on the preparation of the albumin or may vary on the strength concentration of the albumin in the serum. This trial used 20% albumin to achieve a target albumin levels, limiting the comparability with the results of a SAFE study, which used 4% albumin versus normal saline. Coming to strengths of the study, it was a multi-center design study with a stratified randomization. Clinically relevant patient population were taken. Clear and patient-centered primary outcome was set. Comprehensive secondary outcomes were also set, and standardized protocol with targeted intervention was done. There was rigorous reporting and oversight. Coming to the limitations, the premature termination made the study underpowered. They were not able to achieve a higher proportion of patients with serum albumin concentration of more than 3 gram per deciliter, and the use of albumin in the control group, however, required only in the early resuscitative phase on admission, whereas the trial aimed at the albumin substitution beyond the hemodynamic stabilization may act as a limitation of this study. Now, coming to the author's conclusion, in this randomized clinical trial study of patients with septic shock, albumin administration aiming to maintain a serum albumin concentration of 3 gram per deciliter or more was safe but did not improve 90-day survival in these patients. Uncertainty remains due to the premature termination of the study. Coming to critical analysis, this study addressed a clearly formulated research question, and the assignment of participants to the intervention was randomized. All the participants who entered the study were accounted for at its conclusion, and the participants were not blind to the intervention were given, as well as the investigators and the people assessing the outcome were not blinded. The study groups were similar at the start of the randomized control trial, and apart from the experimental intervention, both the group received same level of care. And the effects of the intervention were also reported comprehensively. The precision of the estimate of the intervention or the treatment was reported, and the benefits of the experimental intervention outweigh the harm or cost. No, because the cost of the albumin is significantly higher than balanced steroids. Now, I can't tell if the result can be applied in my local population because an Indian population and the phenotypes of sepsis in our population can be different than the European population. And I can't tell if the experimental intervention will provide a greater value to people in my care than any existing intervention. Thank you.
Thank you very much, Mayank.
Yes.
And now it is set for discussion with the panelists as I take over from here. And as I can start with Dr. Daga. Dr. Daga, sir,
Yeah.
there is no doubt, because the studies have umpteen number of times shown that hypoalbuminemia due to any cause has a worse prognosis, both in trauma patients and sepsis patients and always so and forth. But why is it so that when we are supplementing albumin, we are not able to manifest in terms of real-time situations or an improvement in the mortality? Is it because, as we have seen in this study as well as in the previous studies, that we are targeting something around 3 and which is failing, and it is the level is becoming around 2.2? So had we set a higher target of 4 and we would have reached a level of 3, would that have made a difference, or what else do you think, sir?
I know it's a very loaded question, Anirban. Very difficult to answer. And my being working in a liver hospital now for 4 years, we face this challenge very often. And if you look into this study also, the number of patients with liver disease were, I think, 5, 3 or something, very small number. We don't know what happened to them. That is one challenge. But of course, world over, various societies, whether it is EASL or whether it is ASLD and everything, till now they have not produced any evidence of albumin level above 3, even for these patients of cirrhosis. That's one part of it. But on the other hand, as rightly said by your presenter and all that, there are many challenges, the quality of albumin you are using. And if you look into this trial, the genesis of this trial was when the earlier trial with the albumin was used within even first 6 hours also. Here they were specific that they will not use albumin till first 6 hours. Only after 6 hours they will randomize. So they were trying to hemodynamically stabilize these subjects and then trying to look into that. And if you look into the population here, the other factor was, as rightly pointed, was more so many of them were surgical candidates. Some of them even emergency surgery immediately after that. So, and as all experts know and all that, except for a traumatic brain injury, where would certainly not use that, the answer is very difficult to reach, whether you keep it at 3.5, because in this trial, they were not able to maintain at 3 and not even 50, I think 60, 70% patients, they were not able to maintain,
Right.
if you see that graph. So if you're not able to maintain, then that's very, very difficult. Secondly, other aspect is about, what were they? I mean, the requirement of the vasopressors were almost similar as they have shown it in this patient.
Yes.
But how much was the fluid given initially? That also they have shown. Although they show in the chart that the fluid given is not much different, but if you look into the number, the fluid given in albumin group is definitely lower overall
Absolutely.
fluid.
Big
So
difference.
that's a big challenge. So it is very difficult to answer whether you keep it at 3.5 or 4. As of now, I would say 3 is good enough, but you need to really look into, because here this study is so underpowered that in ultimate analysis, not even those 400, they just
Absolutely,
have
sir. The
200
study is
patients.
too
They had just
underpowered.
200 left, with which completed the whole protocol.
In the
That's
SAFE
right.
study, there were nearly 7,000 patients, 6,997. And
Yeah,
in the Albios, there were around 1,800 patients.
1800 patients. Yeah. So
1,800
here it
patients.
is too
So
less, and if you look into the final analysis, the 90-day mortality which they were looking into, here there were hardly 200 patients left.
exactly.
That's
So this is something which we cannot. Dr. Pramod, if I ask you that, see, we are also seeing that more of 50% of the patients in the control group have finally got albumin, and the same thing had happened in the Albios trial also, because if someone had some indications other than this, we cannot be denied. No, so ultimately, when we are doing this study, we end up comparing, giving a lot of albumin to the control group and a lot of maybe a less than normal to the study group. What is this? Is this a reason, a strong reason to believe, or somewhat strong reason to believe, that why this difference is not manifest in numbers?
Yeah, again, first of all, Anirban, thank you for the opportunity to be here with all these experts as well as the training. And I would like to thank Mayank for a wonderful job of dissecting the article and showing to the entire group. And as Dr. Daga pointed out, so the complexity of this scenario is well acknowledged by the treating physicians as well as like everybody, those who really interest in medicine over the years. The question arises that we do have a preposition that yes, albumin is supposed to help us for period. As Mayank pointed out nicely, the assumption that albumin is beneficial is not questionable, because we all knew that there is two part, which he nicely pointed out, or maybe embedded on the PowerPoint. One is your oncotic part, the other one is non-oncotic part. And particularly when it comes to the resuscitations in sepsis patients or septic shock patients, we are focusing the combination of these two things. One is your oncotic properties, number two is the non-oncotic properties. We all have to acknowledge that which component of the albumin is going to help us at what time. That's the question. So when we dissect all the trial, including the ARISS trials, the premise is, are we doing justice to these two components with respect to the albumin? If the answer to the question is no, then we will not have the like result what you are asking to me. So that's my take on this. So just to give my 2 cents on here. The first part, which is the traditional thought process, traditional way we all learn and been told that, yes, if I give albumin, as you nicely asked Dr. Daga, that should I increase my albumin from 3 to 4, or maybe 4, more than 4, to achieve the goal, and that will give me a positive value? That's a wonderful hypothesis that is based on the fact that higher the albumin level, higher is your oncotic pressure. And if we all believe on the Starling theory that we will have potentially higher mean arterial goal or lack of extravasations in the resuscitation, will have a positive part. That's what the theoretical benefit. But if we believe that, is it practically possible to achieve that? The answer is no. Why? Because the studies like this one and the previous studies has also shown us that it's not possible to really achieve that goal all the time, because sepsis by definition and the septic shock is a dynamic process. Higher the number of organ failure, worse is the problem for us. So that's my thing, like why we cannot achieve this goal even if going for one versus other, like higher level. As I just wanted to comment with Dr. Daga's experience and maybe ask him to share, like we do have a nicely done studies, as well as both retrospective as well as randomized trial, that in the subgroup of populations with liver failure or liver related sepsis, albumin is does showing a benefit. Why cannot we replicate this in this population? That's $1 million questions, to be honest. I don't know the answer to that, but there is something to this question. Is in the context, we need to see that is the role of albumin is different in patients those you have no capacity to generate versus those you are hypercatabolic, like the sepsis patients, to produce the lower albumin. So that's what is the take. I hope it's a long rounded answer, but I'm just giving you
I get your point. I think we get your point that you have mentioned, although with a bit of twist. Anyways, coming to Dr. Kansal, Amit, if you look into the studies and their criteria, the methodology adopted, they say that it was 6 hours and 24 hours, not before 6 hours, not later than 24 hours. Now, is it always possible to confirm the diagnosis and administer albumin within 24 hours? It is maybe possible for you in Singapore, but I really doubt in every center around the globe. What is your take on that?
I guess the authors have done it nicely in a way. Septic shock, that's beyond doubt. That's a very objective statement after the initial resuscitation, which we have to assume that using our bedside tools, increasingly the ultrasound tools, we have already established that we have ruled out a pure cardiogenic, a pure hypovolemic shock. And here we are where we have tried to optimize the fluids. And now we are heading for the vasopressor. So that itself is a very objective kind of definition. So
And also,
that way,
if
I
I
think
add,
we are going
okay,
good.
fine, finish it. Yeah, you can complete. Please carry on.
So that part in 6 to 24 hours. Then, if we think about it, a patient comes to the emergency department. They're initially just sepsis, and there is a couple of hours before they declare themselves, many of them, into septic shock. So that gives us more room. So I guess on that basis, in the first couple of hours, if we are reaching for antibiotics, and again, that's why Surviving Sepsis campaign also leaves it very open, very clear evidence of infection, probability of infection, higher risk of infection. So if you are reaching for antibiotics, chances are you are calling it sepsis. If you are reaching for vasopressors, we are calling it septic shock. So I guess that identifying this patient group should be reasonably possible within that 24-hour window. And that's how they have left the window even broader so that by the time we'll have something.
So I want to add one more question to you, since that was a short question, by the way. But is that if you see that figure again, you see that only the median days was only 5 for those who were receiving the drug, the albumin, and only 15 patients went to receiving for the 28 days. Now, do you think again, because this duration of 5 days was also a bit too short to compare it with the control group, many of whom have otherwise also received albumin by default?
So when we look at our average patient stay, by third, fourth day, they have declared either many of them don't do well, they pass on, many of them do well. So our average length of stay is around in ICU patients. Again, depends on severity, depends on the unit you are working in. I'm sure if I'm working in Dr. Daga's unit with the liver failure patients, they are probably longer stayers. So average would be around that. So median will be around that 4-5 day mark. So this study's idea was to continue while they're in ICU. And I think that fits with my kind of patients, 4-5 days median stay, and then out. I have something interesting to add though. Like, I think we have to stop combining 20% and 4%.
I was
And
coming
I'll
into that.
try.
Okay, yeah, please continue.
So there are studies. So let's say there was this pilot study a long time back,
No,
which
the SAFE
suggested
study
that
had
among
used
100
4%.
patients.
The SAFE study had used 4%.
Yeah, no, another pilot study of 100 patients. This was, I think, in 2006.
Yeah, that which compared 20 versus 5. Yeah.
So that was 20%, and that showed some benefits. Fine. After that, alveolus came out, and alveolus suggested, so from mixed population of critically ill, we went to sepsis and septic shock. Then finally, we went to septic shock in our current trial. So this is 20% of albumin. Now, talking about patients with sepsis and cirrhosis. So the ALPS study, which was done with 20% albumin, actually showed no difference in mortality, some improved outcomes in terms of lactate and volume state, but 22% patients had to discontinue because of pulmonary complications.
Yeah,
Then they were,
that's absolutely
course,
right. Yeah, sorry,
yes,
absolutely
Dr.
right. Go ahead.
That was the
So,
first work. 22% patients had to stop the treatment with 20% albumin cirrhosis with sepsis. Then there was another one where 20% patients developed pulmonary complications. And one of the thoughts has been whether pneumonia predisposes, age predisposes, or 20% is bad for the lung. On top of it, we are talking about bleeding complications, and that comes from cardiac surgery patients. Again, studies show that albumin probably hemodilutes, and that's how cardiac surgery patients, even I think sepsis with liver failure also are cirrhosis with sepsis also at risk of bleeding. So there are two problems. Now, in this study, there were only 5% patients who had respiratory complications. So maybe, so that's very interesting. That 20% seems to be more harmful than 4%. Oh,
Absolutely right. I think just wanted to add a couple of things to that, if I'm allowed to.
Yeah, please,
That
sir.
in these patients, when the ALP study and all that, they ultimately, they were able to, kind of, I think sample size was not statistically powered to reach. I mean, it was not reached there as well, if I remember. And prior to that, they had done a study which was 5% albumin infusion as bolus doses initially. This was a frisk study. In emergency, within first 3 hours, instead of giving them a saline or a crystalloid bolus, they tried to give these patients a 5% albumin infusion as a bolus, or the same dose, 50 ml per kilogram per hour within half an hour and all that. That study did show a benefit, but again, that was also underpowered. So these cirrhotic patients, the risk, as Dr. Kansal pointed out, increased bleeding risk would occur when you use a lot of albumin. That's a big challenge in these patients. And again, the hemodynamics and the fluid balance, there remains a very, very critical. So now, I don't think so. During ALPS, they were able to use much of hemodynamic monitoring that frequently. But now, if you use them very frequently, you have to be very, very cautious in using that. And I also agree with earlier from Dr. Sorry, when he
Pramod.
was talking, yeah, Dr. Pramod, when he was talking, absolutely right that yes, reaching that level, what would happen? You don't know even at this level what is happening. So theoretically looks good, but you have to be very, very cautious.
So, sir,
So
based upon, yeah, Pramod, you want to add?
yeah, I think I just wanted to jump onto what Dr. Kansal suggested with respect to the percentage or this albumin. So I think again we need to be very pragmatic about the interpretation. That's again I'm just telling like so if we read the article and then come to the current sense, it has been evolving like how and this percentage come into the questions. 4% albumin or 4 to 5% of albumin is considered as hypotonic, and the hypotonicity is being considered as harmful, and that is being proven, or one of the comment with respect to that why we should avoid these things for the traumatic brain injury because of the hypotonicity and potential implication with ICP. So that's what it is. Then the question arises that yes, if we goes hyperoncotic, probably the osmolality will be higher and it will help. So the question regarding whether 20% albumin is better than the 5% with respect to the so-called targeted patient's outcome is remain debatable, but the signal is not in favor of the lower concentration. Rather, all the signals are in favor of 20%, including the last analysis, if I don't remember, that was somewhere in 2023. And then we all have to accept that where these people like the ARISS trial, the current trials, the concept of 6 to 24 hour 20% albumin, like where does it come? It came with the idea to possibly fill the gap which was there or in the previous things, but unfortunately it's under our trial. That's it.
Uh,
True.
absolutely right. Absolutely right, Dr. Pramod. And I mean, practically now we are not using, at least in patients with shock and all that, 5% albumin. We are not using that. If at all we have to give, it has to be 20%. You have to see the fluid balance and everything in the need be. That 5%, 4% albumin is
It's
absolutely
gone.
not needed. It's completely gone out of.
Yeah. But one thing which comes to my mind, I asked Dr. Dagadar sir that going by these results of this trial and knowing that excessive fluid administration or accumulative high fluid balance may be harmful, how do you identify, based upon what we know from this study, that who is going to benefit from using albumin or who is not going to benefit?
So that's, yeah, absolutely right. I think what has happened is that based on this trial, it was hemodynamic stabilization, and then thinking in terms of not achieving that, and then giving them albumin after your initial resuscitation. But as such, if we look into septic shock patients and all that, where where they are vasodilated and where they have all these issues about your tissue your perfusion and all that, so it is very, very critical that you start using 2 or 3 bedside tools, and that has to be very dynamic. And as in the beginning, your resident, I mean, your fellow presented that, yes, we need to know what is the sepsis phenotype. So that is also another area. Otherwise, the debate about crystalloid, whether you give a balanced or a saline, that debate is at the moment looks over, but I think it is still on. So that is one aspect. And the second aspect is about whom to give albumin in addition to the fluids. That will only be decided by dynamic indices, not by a particular cutoff. I don't find anything like a cutoff I can give you, or a particular one single test I can give you. Uh, whether a POCUS or whether your capillary refill time or whether your passive leg raise test and all that. That those are different things. And albumin requirement per se, two things you have to be careful. One is the cost is definitely a factor. But on the top of that, here the patients many of them were surgical patients, while in Albios trial, majority of them were medical patients. The surgical patients were less. So again, in that scenario, uh, what is the outcome? I don't have a definite answer.
So probably it is going to the phenotype which will have the final say, and there may be reasons, plenty of reasons other than the albumin, which might interplay along with the own albumins. As we come across so many studies which are now being published which were conducted during the COVID times, I come to Dr. Kansal on that. And I will go with the same question to Pramod after you. And we find that these studies are getting published, but without the adequate power, because it was out of the control because on the view of the COVID, which was prevalent that time, true. But how we take the results, what should have been the fate of the study? Is it right to just come up with the results when the sample size haven't met, particularly in these studies, which has a low generalizability? If you see the number of eligible population versus the patients who were included, after exclusion, that a large number of people were excluded. So how do we digest the results that we get after all these standard deductions? Amit.
So yeah, no, that's a very interesting question. And I think whatever said and done, we have to kind of thank the researchers. They really would have put in a lot of effort to get this going from the beginning, planning a very good trial with reasonable internal validity, getting the study sites up, getting the albumin consistently being delivered. So a lot of effort would have gone in. And we can see that when we are part of multi-central trials, how much effort goes in. So that's part, I think, let's give it to the authors. And then you're stuck because now the practices are changing. We are probably fluid resuscitating in a different way. There's no time. So one way is to give a break and then start the study again. But as we have seen in some of the neurosurgical studies, specifically, that it spans over 10 years. And then you're like, how do I use these results? So I guess from that point of view, as a bedside clinician, I will value the results in a timely manner, because anyways, we are not going to make a decision based on one study. We will have a prior kind of probability in a way, in our mind, we are doing a Bayesian kind of analysis. We have our prior learning, and we then put the results of a new study, realizing that yes, it is underpowered, XYZ. And that's how. So when I think about this study, like 400 patients compared to, I don't know, Albios had a subgroup of septic shock, which probably would have been similar size. So maybe in that regard, a meta-analysis will serve that purpose. So I'm okay with the results being published as long as it's a reasonable number and it's not just 100. It's like still 400 rather than dying in a bunch of papers. Yeah. That's how I feel.
So we can all understand that we need to first identify that specific subgroup or subgroups which might exist, and then try to do this study or conducts a similar study and with a control and see what exact benefit it incurs upon. But going by that, yeah,
And
Pramod.
Irfan, I just wanted to say one thing. These subgroup analysis, and especially in an underpowered study, they
It
throws
don't
a lot
carry
of
much weight. I
questions.
get it.
So you have to be careful. But I fully agree that yes, it's not a bad in terms of they are saying that it is safe. It is safe. They are still not promoting that you give it. I mean, it's for you to judge it and think of, because if you compare the number from SAFE and LBOS, subgroup of LBOS was around 600, and this is around 400. So that number doesn't seem much
It
different.
exists nowhere.
So,
It is
so
nowhere
yeah,
compared.
so that's a in a way interpretation like that. And then if you assume that you expect a 15% reduction in outcome, mortality outcome, and all that, which they did in this, so that was a fairly good calculation they wanted to do, provided they were able to reach that sample. So
Exactly.
that is very
That is very, and we have seen that in that we have been facing these problems in the earlier studies which were conducted with albumin too. But we went on to use our judgment, our clinical judgment, to design studies which seemed did not make much of a difference. So so this may be the reason that there was a gradual shift from 4% to 20%. Therefore, there was. But do you think, Dr. Pramod, that using that 60 gram of albumin on day one, followed by 40 to 80 grams, depending upon the level on day two on, so is that a mix and match type or little lacking in scientific content?
Yeah, again, this is an excellent question. I mean, but at least I can take part of your brain to really think about what's going on as we speak. So the first and foremost things we all have to acknowledge and then give kudos to the trialist for doing this trial and publishing to fill up the gap so that we can, as a clinicians, those who are taking care of the patient at the bedside, they can think in the appropriate way. But we also, as Dr. Amit pointed out, we also have to be very pragmatic about interpretation of this trial results. So when I look into this trial, when it came up, so it immediately came to me the term that which is probably everyone there, early terminations of ARISS trial. The question is, why did the trial got early terminated? It's not just because of the COVID. That is also another component onto that things you can look into that same sentence is the slow recruitment. So the question is, why did this slow recruitment is there? The slow recruitment is because of a simple reason. Hesitation of the physician like you, me, and others, those who are at bedside, to adopt the trial protocol. And our hesitation is based on the simple fact with the previous trial result. We all, as physicians, knew that it's not a black and white, it's not the miracle things. So we need to be pragmatic about our approach. To answer your questions, 60 to 80 gram, to be honest, if I am the physician, I'll be question mark because it depends upon where is my patient. Is it the ARDS? How much is the fluid they already got it? How much is their chances of getting the capillary leak? Are they renal failure? Because these are all coming into the question in my mind. So the hesitations needs to be kept into consideration for future research study. So in that case, in my opinion, there are other studies applied. So the pragmatic approach of future studies should be include the current decision-making process of the physician at the bedside so that they can adopt the study protocol. Otherwise, we'll coming back to the same question again and again without moving the needle to the other directions. That's
right. It will be all moving
absolutely
around the
right.
circle. Yes, Amit.
Because go ahead.
You,
Dr.
Yeah.
Amit, go ahead.
Dr. Daga, please go ahead.
No, you go ahead. You go ahead.
Now, so that's a great point, Pramod, that you have made. And I was kind of dying to make a similar kind of comment. Like, gone are the days we would just give 30 ml per kg of fluid without thinking about it. So, gone are the days we give 60 to 80 gram of albumin just because we can. And we know all these kind of regimented therapies are not going to work time and again. Low versus high blood pressure, why will it work? 30 ml of fluid, why will it work? So that way, probably, if albumin works at all, and maybe there are some patients where it works, the best way be maybe the 4% or 5% albumin, where we are using the usual volume assessment. That gives me much more room to give albumin in that way. So as the Surviving Sepsis campaign puts out, first choice, always crystalloid. Once you think you have given enough crystalloids and there is no definition to it, and if you think 4% albumin might help, you will do it with the usual guidance of hemodynamics.
So I just interrupt you there. Sorry to interrupt you. I mean, so you mean to say that we have to give albumin for the simple reason that we want to avoid crystalloids, not to improve outcome?
So again, based on, let's say, an expert opinion from Surviving Sepsis, based on the outcomes of, let's say, the SAFE study, there is room. So if somebody wants to give albumin after a large volume recess, in the hope that we can reduce the volume given, it is justifiable. If I decide not to give, you cannot say it's wrong. And if I say maybe, so that's what Surviving Sepsis campaign, but it has to be tailored according to the hemodynamic variables, realizing the risk of cost, realizing the risk that it can actually worsen the leakage of albumin into the capillary space and worsen, we know it worsens traumatic brain injury, it can worsen the renal capsular pressure as well, perirenal pressure as well. So I'm just reiterating the Surviving Sepsis campaign kind of 26 guideline to say some room, but not upfront, definitely not upfront.
Yes, Dr. Daga.
Yeah, absolutely right. I think everyone actually, Pramod, and they put it very correctly, that's the take home is that see your patient and then decide, because again, Surviving Sepsis about this quoting when it is saying moderate, this thing and low evidence. So about albumin, it is still writing the same. So
you are muted, sir.
Sorry, more than 20, 25 years the albumin studies are on, and we are still not reached that thing. So I think it's a balanced approach as suggested by Pramod and Amit. I think that's what you have to do. You still have to look into that aspect. Otherwise, that hesitation word used by him by the physician, that these trials would help in coming out of those hesitation and all that, and definitely give confidence to the physicians that yes, we can use that.
And
Satya, Pramod.
One more comment, as Amit pointed out, and you asked or put him in the direct line of fire that with respect to the patient outcome. So we all have to. I think this is again. I'm optimistic about the role of albumin in future, particularly one patient-centric outcome. Okay, this is again a biased statement. It's because that is a trial, if I remember correctly, was published 2024 or 23, that if we give hyperoncotic albumin with the target called the microcirculations, it has been shown that number one, it does improve the microcirculatory functions at 4 hours, 6 hours. It decreases the lactate clearance, and moreover, I'm a kidney person, so it does help in protecting the kidney. These are the signal in a small trial. So when it comes to the patient-centric approach of the future trial with respect to albumin, I think mortality should be equally balanced with the other patient-centric approach, because it's not just the one intervention which is mainly responsible or going to make the difference in the patient outcome. It's many. So if we split and then find out what is appropriate, that's going to probably give us more confidence.
Yeah, well said. Pramod, now since we are running out of time, Satya, can you take a few questions from the chat box if there are any? Or else we can pass to the chairman.
There was one question on cardiac dysfunction in septic patients, how it's going to affect the outcome when you give albumin in them.
Okay, I think the answer it has already been answered by Dr. Daga in the course of the statements that we're not going to use that drug in patients with cardiac dysfunction with sepsis.
Be very careful. I think you
I
do
just
it.
have one question, sir. If I could.
Yeah.
I mean, in the study, they included both sepsis, severe sepsis, septic shock patients. If there had been some stratification in terms of, the severity of sepsis, could we have?
No, they have stratified on the basis of SAPS, lactate, SOFA, although the stratification was there.
The noradrenaline requirement, the phenotypic background of whether it's hyperinflammatory or not to begin with, would that have made some difference?
Sepsis phenotypes, yeah.
Yeah, that was not there. That was not there. Other all things were there.
Other all things were there.
Yeah.
Any other questions are there, or it goes back to the chairperson? Yeah. I think Dr. Ranvinder will have the final say as a chairperson.
Yeah, so as you can see that the study in fact had a number of limitations, and now finally coming to the conclusion of the study is that although in this randomized clinical trial, this study of patients in septic shock, we see that the albumin administration, the aim was to maintain a levels of more than 3 gram per deciliter. How we arrived that how much albumin to be given to the patient, again it is very not very clear that how on we are giving, if it is between 2 to 2.5, they are giving 60 gram and all. So again, that is not very clear. So here this trial in fact basically shows that it did not that although the albumin administration is safe on the basis of adverse events and the serious adverse events, it proved to be safe, but it did not improve the 90-day survival in these patients. And moreover, the uncertainty remains because there was a premature termination of the trial. So in fact, it was an underpowered study, and mainly it could be because of the COVID at the same time. It was underpowered, and as sir has very rightly pointed out, that probably the physicians were very hesitant to enroll the patients in the trial, seeing the amount of albumin to be given. So I think that would be the final conclusion of the study. So we need more kind of studies to finally come to a result whether albumin would be useful in patients of septic shock. So that was the basic premise of this trial. If we can if we can come to the hypothesis, if we can prove the hypothesis that albumin is safe, then it can definitely improve the survival. It can give a survival benefit to the patients. But if we cannot prove it, then at least we can have a restrictive use of albumin. It is a very expensive product and we can restrict it. So as such, the study does not has any mortality difference.
I think Satya or Santosh, you can give your vote of thanks because we have already crossed our time. But in case there is anything else you can want to mention, you can.
It was an insightful discussion, sir. And on behalf of ISCCM, we thank all the panelists for their expert opinions and the discussion. And we thank the moderator, Dr. Anirban, for his, for carefully curating this. We thank the person and the presenter as well, and my co-host, Dr. Santosh. So thank you, everyone. Have a good.
Thank you, sir.
Thank you, Anirban, for a wonderful discussion.
Thank you,
everyone.
Thank you.
Great meeting all of you.
Thank you, sir.
Thank you.